Alright, so today I'm going to present on my chronic injury in dance for my presentation. To begin with, introduction. Dance is a rigorous athletic activity and an art form. It is. I'm used to working in the traditional setting with football. Dance is not football. I started dance last year working with dance patients, and it's completely different than I am used to. Usually dancers dance through pain, injury for a multitude of reasons. Some of those reasons could include rehearsals, fear of being told no, they cannot continue on, cannot play, rehearse. We're used to thinking in the sense of playing, but rehearsing, big thing. Not being able to perform in their show. Majority of the injuries I saw were overuse or chronic, and as you can see here, about 60 to 76% of all injuries in dance are chronic or overuse in nature. Bronner et al., Nilsson et al., Anderson and Solomon et al. As you see, these are from 86 all the way up to 2008, and there are some more articles coming out more recently, as you see, Shaw's in 2012, that are starting to say these same things. I had to kind of change the way I evaluate because I was so used to working football, acute injury, hey, it's an ankle sprain, I know it's an ankle, I know it's an ACL. Now, why are these patients complaining of patellar tendonitis for a year? You know, what am I missing? And I am missing some things. Biomechanical. I think that this could be a big factor. We have something called turnout in dance. It's external rotation of the lower extremities. It can be so extreme that the feet, form a 180-degree angle. So, feet here, feet turn all the way out here. I can't even do it. So, 180-degree angle. That and turn with that and dancing for 8 to 12 hours a week, which typically my patients do, for 16 weeks at a time, straight weeks at a time, that can cause overuse injury. As you see, I have ballet written down here. Ballet dancers usually have 5 different points of turnout, 1 through 5, 1, 2, 3, 4, 5. If they are a ballet dancer, they're always up, plantar flexed, always up on the tip of their toes, and in turnout. So as you can see, this isn't the best anatomical position for anybody to be, let alone an athlete, a patient. And most turnout cases, the lower leg from the knee down is about 10 to 35 degrees of that motion, and the rest comes from the hip. So think of a dancer, performing the first couple weeks here. We're starting up Sunday. The first 30 seconds of a song, that's all they know, that's all they get to, maybe for the first 4 to 6 weeks. It starts off slow for them. They're doing this for 12 hours a week for 6 weeks. That's a lot of extreme torque, extreme biomechanical stress. So are we missing the boat? Am I missing the boat on something with these patients? I think I am. I'll get to that. Footwear. First thing that the dancers do when they get to the dance studio is take off their shoes. They don't wear anything on their foot at any point. Could this be causing, foot pain, ankle pain? As we'll see here in a couple minutes, foot and ankle pain accounts for the majority of what we see for dance injuries. Epidemiological statistics. A majority of injuries are to the foot and ankle. I have some statistics on the next slide. Garrick, Ojofiamente, I can't pronounce his name, and Ronco. They all stated that majority of these injuries that dancers sustain are to the foot and ankle. Majority of those injuries are overuse. Lee Anderson, Nilsson, Gamboa. I have this slide coming up right here. Study. Percent foot and ankle injuries and overuse injuries. As you can, I'm pointing to the screen. As you can see with foot and ankle injuries, a couple of these studies are in the 50s. Gamboa and Nilsson. Couple of them are in the 40%. So it averages out to almost 43% of injuries in dancers are to the foot and ankle. What makes me angry is these studies, they don't break down, is it just the foot, is it just the ankle? They lump them together. They do this for hamstrings, I've noticed in the dance literature, for epidemiological studies. If it's a hamstring, they say they lump it into thigh or upper quadriceps area. Well, upper quadriceps, is it a quadriceps? Is it a hamstring? Is it an I band or IT band? What is it? So that's just my little rant on that. It makes me angry. I think that we should have better defined operational definitions. For overuse injuries, you can see all these studies said or talked about overuse injury, but only 3 of them gave statistical numbers. So almost 61% of the injuries that these 5-6 studies have seen were overuse. I can attest to that. I'd say 98% of what I see is overuse. Literally last year I had 1 acute injury. Now, depends how you define acute, but I had 1 ankle sprain last year. Everything else I saw were patients that were injured before I got there, or injured during the semester and didn't tell me, and had pain throughout the semester and didn't tell me until it became too unbearable. So what do? Well, I had a patient come in today. She complained of bilateral patellotendinitis last year. I was a shotgunner. I'm still a shotgunner. I hate to admit it. I'm not there yet. I did a lot of traditional treatments, as you see on the screen here. I did modalities, stim, ultrasound, massage. I do a little bit of everything, and it really didn't help her. She came in today, didn't do anything all summer, and still had she had a DPAT score of 42, but she had really increased her pain throughout the summer and not doing anything, which made me a little worried. So I evaluated her. I actually didn't do the FMSSFMA yet today on her. We'll probably do that Monday. She only had about 10-15 minutes between classes. So gave her the DPAS, and we talked a little bit. So prior to last year, the dancers and patients I work with had no healthcare provider to go to. They would just deal with their injuries. The athletics department wouldn't let them be seen by our head athletic trainer. They couldn't really go anywhere. Some of the dancers are afraid to come in to see me because they're afraid to be told they can't dance, which I can understand. Just like any athlete, just like a basketball player, is it a basketball player that sprains their ankle, rolls their ankle, may not sprain it, but rolls it and in some pain? They don't want to tell you that, hey, I rolled my ankle, because they want to play that day, the next day, whatever it might be. So they're athletes too. Just because you think dance, it's not really a sport, or they're not athletes. No, they are. I'm not an athlete, but I couldn't do a lot of the things they do. And some athletic trainer, or some don't understand what an athletic trainer does. That's very true. A lot of them don't understand what I do and what my students are there for. I thought I did a good enough job of explaining that last year, and clearly I didn't. So we start up Sunday, like I said, and we'll hopefully get better at that this year, explaining what we do and showing them that we can help them, hopefully with only a few treatments, and get better and still dance. So as I said before, I tried to alter some biomechanics. Clearly that didn't work. Biomechanics did not work. Definitely no. Modalities, stim, ultrasound, massage. I'm a shotgunner. I don't want to be a shotgunner anymore. I want to be a rifler. What I'm doing clearly isn't working. I still, this girl came in today for pain she's had over a year now. So this brings me to the FMSSFMA and Y balance. So, FMS, we all know, this can pick up on weaknesses, imbalances. Greg Cook and his boys, Plisky and Kiesel and all them, they have used FMS to screen a patient population and track over time. They've done that with football players and NCAA, high school basketball players. We'll get to that in a second too. So can I use FMS in my patient population and track over time injuries? I think I can. FMSSFMA, too many abbreviations. We're going to be doing that anyway, so I will include that in my evaluation no matter what now, which we just found out this week. So would this be better to use for chronic pain or injury? We don't know. FMSSFMA really hasn't been studied in chronic injury pain situations. Now the Y balance intrigues me because they have an upper and lower quarter Y balance. The majority of everything I see, I'd say 90% of the patients I see come in with lower extremity complaints. Being dance, we don't really see too many upper extremity complaints, but we can. So this measures functional balance. Pliskett et al. 2009 talked about that. They looked at high schoolers doing the STAR excursion balance test, and they compared it with the Y balance and some normative data between the SEBT and that, and I think it would work well in my patient population. Now this is the cat's meow to me. Positional release therapy. I love this. I'm not an expert by any means on this yet. I just ordered a book and we'll get there. So this creates motion through restrictive barriers. So you can put the patient in a position of comfort, hold it for about 90 seconds, and they should start to feel relief. It has shown benefits with chronic pain. The Braun, Fort et al. 2010 article talks about chronic pain. Now this is a systematic review with about 300 references, and I just found this article Wednesday, and I'm going through the 300 references right now to see which articles I can pull up and I can get from the library. So I'm not quite there yet, and I know I need to do some more work in the literature for chronic pain and PRT, but I know it's ease of use for the clinician. It's very easy to use, and it's effective for the patient. It only takes 90 seconds. Why would you not do that? If it will help your patient in 90 seconds, why not? So 2 action research area questions that I want to talk about. First one is, can we, my students and I say my students because I'm an ACI preceptor, whatever Katie's calling it this week, and my students are very interested in what I'm doing with the DAT. At the end of the semester, academic year, we have an undergraduate research conference in April. They would like to help me out and do some things with what I will be doing and present that at the research conference, which I'm all for. It's a collaborative, agreement between me and biology, athletic training, and fine and performing arts and theater. So our administration really likes it because it's interdisciplinary, collaborative research. So can we screen dancers to identify biomechanical issues that can cause overuse or chronic injury? Action research answer, I think yes, we can. We can use the SFMA or FMS and or Y balance to screen for these. Which would work better in my patient population though? I think the FMS and the Y balance would work. We're going to be already doing the SFMA when we evaluate a patient, so why not use the FMS? My attending clinician, he just finished his dissertation and PhD on FMS and Y balance. Pliskett was his chair of this dissertation committee. So I think I have 2 excellent resources right there at my fingertips. I share an office with him that we could easily, me, my students, you guys could all really use that resource to understand the FMS, Y balance, and do it properly. We already have all the equipment for FMS. We actually have 2 FMS kits and 2 Y balance kits. So we could easily do that. Now my question would be, take the FMSers and track them over time. So would I track them over the patients who get below 14? So injury tracking and DPAS for outcome measures with that last action research slide. DPAS, we know we're doing that. Everybody has to do it. First day, every 3 treatments, return to play, discharge, given. But for the FMS, injury tracking, do I take the patients who perform poorly below a 14? Kissel et al. Says below 14, you're thinking about 37% increased risk for injury on the FMS, and track to see injury rates. I think that could be pretty easily done in my setting. I have a patient population, about 100 to 125 dancers. I have an expert in it, if you will. I have all the equipment. I think that could be a good project. Take patients who perform the SFMA and track injury rates. Now, SFMA, chronic pain, chronic injury, and track them over the semester, academic year. They're 4 years in college with us, with the dance company. See what happens. I find that intriguing. My second action research question is, what intervention can I provide to effectively treat overuse, chronic injury, and or pain? My theory, my answer is positional release therapy technique. But how do I get better trained? Like I had said for a brief second, I ordered a book, Biomechanical. He wrote a book on positional release. He's kind of I guess, the Godfather textbook in this area. And I have seen some seminars that are offered, but they're about $1,000, and I don't have that extra $1,000 right now to go to a conference, or maybe the time. I don't know. I need to get better trained at PRT and do it properly. Hopefully, this book will be here. I was hoping today, and I will watch more videos on this. But another thing I get caught up on are the next two bullet points here. How do I know it will work for that specific pathology, say patellar tendonitis or chronic Achilles tendonitis, any of the itises? There's some research out there. I need to dive into that more, and I need to get better trained at it. But do I need to know the pathology? We talked about that this summer. I couldn't wrap my head around it this summer. I want to know what's wrong, not just treat the pain. But does it really matter? As long as they feel better, does it matter? In my head, yes, because, hey, if I have cancer but you give me a shot of something and I feel better, well, I feel better, but I still have the cancer. So that scares me that I don't know the pathology to a point. Now, maybe I'm not wrapping my head around this all the way yet. Well, I know I'm not wrapping my head around this all the way. But for positional release therapy, I think that this shows great benefit for chronic pain from what I know already. So outcome measures for the PRT. DPAS, obviously, numeric pain scale. Every day they come in, we give them a pain scale. What do they feel like? Hopefully it's getting better. Two or more, right? Minimal clinical significant difference. I can't talk. Chronic pain scale. I have a textbook in my office that talks about chronic pain. It's an outcomes book. It's about 400 pages of different outcome measure scales. I could not find one for chronic pain. There were plenty in there for the foot and ankle and lower extremity that have been validated, but none for chronic pain. Is there a scale out there that I haven't found yet in the literature? If so, do I need to use it? Already using the DPAS and the MPS, I probably don't need to use it. Now, maybe I would want to use something like that or create my own chronic pain scale and validate it in my patients. I don't think that is the area of advanced practice that I want to be in, though. I could see myself becoming an advanced practitioner in positional release therapy. I think it's like I said, the cat's meow. I think it's got a lot of benefit and not too many negatives. 90 seconds, why not? So conclusion, I want your guys' feedback as my classmates, as my professors, Dr. Nasipany and Dr. Siegmiller, on what you think. You all have different experiences. Some of you have used FMS. I know Vicky and I think Eli have. I want to know your experiences with that. Good, bad, ugly, hopefully good. The SFMA we're going to all be doing, and the Y balance. Has anybody used that, and what have they done with it? PRT, I think Lindsay has had some training in PRT, positional release, and used it this summer and fall preseason camp. I think that it has, like I said, a million benefits and very little negatives. I don't really know that it could actually hurt the patient, but only help the patient. So I think that I would like your feedback, and I want your feedback on SFMA, FMS, Y balance, PRT. My other area that I need to get better at is chronic pain, chronic injury. I need to understand chronic pain injury better first as well. So that's a presentation for AT 630 this fall that I'll be doing on some pain issues. So I need to understand a little bit of that basic science a little bit better first. So I have some of my references here, about 15-20 references. So I look forward to your comments. Please be as nice or as harsh as you wish. Those of you with training in FMS, SFMA to a point, Y balance to a point, and positional release, I'd love to hear from you, your comments. And I thank you for watching and listening.